and welcome back for another deep dive. Today, we're going to be tackling, well, it's a pretty common problem, but a surprisingly complex one. It's recurrent dislocation of the patella.
Or as some people might know it, a dislocating kneecap.
Exactly. So, it's one of those things that sounds kind of minor, right?
Yeah,
But it can really have a huge impact on your life. I mean, just imagine, like, not being able to trust your own knee.
absolutely. And what's so interesting to me about this is that even though, this has been a problem for humans,
Mm.
I imagine for, as long as we've been walking upright,
Oh, for sure.
we're still learning things about it today. And for this deep dive, you actually sent over a medical paper from 1964
Wow.
written by a Swedish surgeon named H. Bratstrom.
Yeah, this is going way back in time. I love it.
Yeah.
I'm excited.
And Bratstrom was really, he was one of the first to take a really systematic approach to trying to understand the causes of this.
Okay, so we're going old school for this one, but that's okay because it sounds pretty intriguing. I was looking at the paper earlier, and the very first thing it starts with is this quote from a surgeon in the 1800s who basically says that everyone's been arguing about kneecap dislocations like for centuries.
It really is this age-old medical debate,
Wow.
you know. And even before we had, X-rays and all of the advanced imaging techniques that we have now,
Right.
clinicians were observing patterns in their patients and noticing that, for example, folks with what's called genu-valgum, so knock knees, they seem more prone to having kneecap dislocations.
Oh, yeah, that makes sense, right? If your legs are kind of angled inward, it's got to change the alignment of the whole joint. But I'm guessing it's not just knock knees, right? There's got to be more to it.
Oh, absolutely. So they also noticed that, patients with a high-riding kneecap, what's called patella alta, also seem to have more issues
Mm.
because the kneecap should be sitting in this groove on the thigh bone, the femur. And if it sits too high, it can make it more likely to slip out of place.
So it's all about that perfect little fit in there. The kneecap's got to stay in its lane, basically. What I find fascinating, too, is it's not just the bones themselves, but the muscles actually play a huge role, too.
Huge role, absolutely. So, for example, one of the main players is a muscle called the vastus medialis, which is part of your quadriceps, your inner thigh muscle. And this acts as kind of like a dynamic stabilizer for the kneecap.
Yeah.
So if it's weak or underdeveloped, it's not going to do its job as well.
Got it. So it's like a whole team effort there. You got the bones that are kind of providing the structure, but then those muscles really keep everything in check. Now, I know you mentioned X-rays earlier, and this is where Bratstrom's research, I think, gets really interesting. He was super intrigued by this idea of femoral dysplasia.
Yeah. This is one of the big sort of controversies or areas of debate back then.
Okay.
And the idea was that in some people, that groove on the thigh bone where the kneecap sits, that it might actually be shallower than usual, and that would make the kneecap more prone to dislocating.
Oh, okay. So it's like a built-in design flaw, kind of. Like some people just have shallower grooves, and that makes them more susceptible to these knee problems.
That was the thought. But here's where it gets kind of tricky. There's a debate about whether this femoral dysplasia was actually a real anatomical difference,
Mm-hmm.
or if it was just an optical illusion based on how the leg was positioned when they were doing the x-rays.
Well, that makes it so hard to study, though, right? How do you figure out what's real and what's not when the way you're even taking the measurement might be influencing things?
Exactly. And Bratstrom actually felt the same way. That was a big part of what motivated him to develop this really standardized x-ray technique.
Okay, so how do you go about that?
So he was super meticulous about patient positioning, about, taking multiple images from different angles and just really precise measurements. And he even went so far as to study 100 men and 100 women with healthy knees, just to establish kind of like a baseline for comparison.
Wow, that's attention to detail. This guy was serious. So what did he find after all that x-raying?
Well, a couple of things. So first of all, he actually found that there's a natural asymmetry between our right and left legs.
Seriously?
The left side often has a shallower groove, even in people without knee problems.
So even if I've never had any knee issues, my left knee might be slightly more prone to something happening just because of that? That's crazy.
Yeah.
Wow, okay. What else?
And he also found that there were differences in that groove shape between men and women, which makes sense. We have different skeletal structures.
Right.
But the thing was that even though he observed those anatomical variations, he didn't find a super strong or direct correlation between the depth of that groove and the likelihood of having kneecap dislocations.
Oh, so it's not just a simple equation like shallow groove equals dislocating kneecap.
Exactly.
There's got to be some other stuff going on.
Exactly. And that's what we'll kind of explore further.
Okay, so it sounds like anatomy is definitely part of the puzzle here, but it's not the whole story.
Right. His research was really about understanding all these factors together.
Yeah.
The anatomy, the biomechanics, and the individual variations.
I'm already so much more intrigued by this than I thought I would be, so I guess next up we got to dive into how he actually applied all these findings to his study of patients with recurrent patellar dislocation.
Exactly. Let's get into it.
Welcome back, everyone. We are officially knee-deep in the world of kneecaps right now, and I, for one, am fascinated.
Yeah, this is some really cool stuff.
It is. We're still exploring that 1964 paper by H. Bratstrom, who, let me tell you, was meticulous in his study of those slippery kneecaps. We're talking about recurrent dislocation of the patella, and so far we've learned that anatomy plays a role, but it's not as simple as, oh, you have a shallow groove, therefore your kneecap is going to dislocate.
Right, exactly. So, he didn't just stop at measuring all those grooves on the thigh bone. He went on to actually study 131 patients who were dealing with recurrent dislocations.
Wow. Okay, so he's got this whole group of people, and he's starting to categorize them, look for clues, look for patterns. I mean, where does he even begin?
Well, he started by looking at which knee was dislocating.
Hmm.
So, was it the right knee, the left knee, or were both knees kind of prone to popping out?
Okay, yeah, that makes sense.
And then he also looked at the age when that first dislocation happened. So did it start in childhood or adolescence, or did it happen later in life?
Yeah, I bet that age of onset thing could reveal a lot about potential causes. But what about trauma? I mean, wouldn't you think that a really traumatic injury, like, a sports injury or a fall, would be the most common trigger?
Yeah, you would think so. And, while most of the patients in his study did report some kind of trauma before their first dislocation, it wasn't always a big dramatic event. Like sometimes it was something as simple as twisting the knee with their foot planted or changing direction quickly.
Wow. So even something that seems really minor like that could be enough to trigger it?
Yeah. And it just highlights, I think, how those anatomical variations we were talking about before, like that shallower groove or weaker supporting muscles, they can really create a situation where even everyday movements put the kneecap at risk.
Oh, wow. So it's like the joint is already kind of primed for that potential slip out. Okay, so let's say that first dislocation happens. Does that make the kneecap like even more vulnerable to future dislocations? Kind of like a slippery slope, literally.
Unfortunately, yeah. That's the nature of recurrent dislocations. Once those supporting structures like ligaments and tendons around the kneecap get stretched or damaged, it becomes easier for it to slip out again.
Okay, so knowing that, I mean, is there anything that can be done to kind of prevent it? Like if someone has that first dislocation, are there things they can do to maybe reduce the chances of it happening again?
That's actually where Brastrom was, I think, really ahead of his time. He was a big advocate for what we would now call conservative treatment after that first dislocation. Things like immobilizing the knee to allow those ligaments and tendons to heal properly.
Okay, so rest and recovery. The body's best friend.
Exactly.
Makes sense. But I guess for those who do go on to experience those recurrent dislocations, did he find any link between how often it happened and the severity of that, what was it, dysplasia, that shallow groove thing?
That's the interesting part. There wasn't a clear-cut correlation.
Right.
So some folks with relatively mild dysplasia had frequent dislocations, while others with more pronounced dysplasia actually had fewer.
Okay, so it's not just a simple equation of, bad anatomy equals bad outcome.
Nope.
I guess it really shows just how complex this whole condition is.
It really does.
I mean, maybe muscle strength or even just like how someone moves could influence how often it happens too.
Right. It's like each person has their own unique combination of those risk factors and triggers. And while Bradstrom didn't have the tools to really get into all those nuances, his research paved the way for, a much more holistic understanding of this.
Well, that's great. So we've got the anatomy part, the trauma, the frequency. But what about the long-term outlook for people who are dealing with this? Did he offer any insight into what the future holds?
Yeah, he actually did. He followed up with his patients several years after treatment, and he categorized their outcomes as either good, fair, or poor, based on their symptoms and how well their knee was functioning.
Okay, so what did he find? Did those with, less dysplasia generally tend to do better in the long run?
There was a trend toward that, yeah. So people with less pronounced dysplasia were more likely to report good outcomes. But and this is really important, it wasn't a guarantee. Some people with less dysplasia still had some problems, while others with, more pronounced dysplasia actually did surprisingly well.
So even if your anatomy isn't, like, perfectly ideal, you can still have a positive outcome.
Absolutely.
That's got to be encouraging to hear. It's not a life sentence of knee
Wait,
problems.
it's just one piece of the puzzle.
That's a really important message, I think, for anyone listening who's dealing with this. It's not just bad luck or some random twist of fate. Brackstrom actually found that recurrent patellar dislocation often runs in families.
Yeah, about a quarter of his patients reported having close relatives who also experienced this.
So genetics could be at play here, too.
Absolutely, yeah. Maybe some families inherit a tendency toward, those shallower kneecap grooves or other anatomical variations.
Oh, that's fascinating. We're talking about research from the 1960s, laying the foundation for what we know now about genetics and kneecaps. Amazing.
It really is pioneering work.
All right, so we've got this historical context, those fascinating findings from Bratstrom. I think it's time to shift gears a bit and talk about treatment. How has the management of this condition evolved since then?
Yeah, let's talk about that. We'll explore everything from those early surgical techniques to the more modern approaches that we have now.
And we are back for the final part of our deep dive into recurrent patellar dislocation. I've got to say, this has been a really wild ride through kneecap history, all thanks to that 1964 paper you found by H. Bratstrom. But I think it's time we brought things into the present and talked about how treatment for this condition has evolved over the years.
Oh, yeah, for sure. It's been a pretty amazing journey, from those early surgical techniques that were, pretty intense, I got to
Oh,
say,
yeah.
to what we have now, which is a much more, how do I say it, a much more tailored, individual-focused approach.
I love it. All right, so let's start with those less invasive options. When someone's dealing with these recurring kneecap dislocations, what are some of the non-surgical things that can be done?
Well, conservative management, it usually begins with strengthening the muscles that help stabilize the kneecap.
Okay, yeah, that makes sense. So it's like giving the kneecap more support from the surrounding muscles.
Exactly. Remember the vastus medialis we talked about, that inner thigh muscle?
Yeah.
That one's really
Got
important.
to build that one up.
So physical therapy is really a cornerstone of this approach. There are targeted exercises that focus on strengthening of the quads, the hamstrings, the hip muscles, really to improve the overall stability and control of the knee.
It's not just about strength, though, right? It's also about kind of retraining those muscles to work together in a more coordinated way.
You got it. Think of it as like fine-tuning the coordination so that they can all keep that kneecap tracking nice and smoothly in its groove.
That makes a lot of sense. And then I've also heard about bracing. Can that help too?
Oh yeah, bracing can be really helpful, especially during activities that put more stress on the knee. It provides some extra support.
So it's kind of like giving those ligaments and tendons a little backup.
Exactly. And there are different types of braces out there. There's simple sleeves that just provide compression, or you can get more structured ones that have straps and hinges for extra stability.
So I guess finding the right brace is kind of like finding the right shoes, right? You need the right fit for your specific needs.
Exactly, yeah.
But what about those cases where, those conservative options just aren't cutting it? When does surgery come into the picture?
Yeah, that's a good question. So surgery is usually considered when, conservative treatments have failed to provide enough relief, or if there's significant damage to the structure surrounding the kneecap.
Gotcha. So like if those ligaments and tendons are stretched beyond repair, surgery might be the only option to actually bring back that stability.
Right, right, in some cases. And thankfully, surgical techniques have come a long way since the days of Bratstrom's research. I mean, we now have minimally invasive procedures that allow for quicker recovery, less scarring.
Oh, that's fantastic. I mean, less pain, less downtime. Who wouldn't want that? But what do these more modern surgical approaches actually involve?
Well, there are a few different ways to go about it. Some surgeries focus on realigning the kneecap by adjusting the tensions that attach to it. So it's kind of like adjusting those guide wires.
Oh, yeah.
And then others involve actually reconstructing damaged ligaments or even deepening that groove on the thigh bone to create a more secure path for the kneecap to track in.
Wow. Okay. So it's like a very targeted, precise approach.
Absolutely. And that's one of the biggest changes, I think, in treating this condition, this
Okay.
shift toward a more individualized plan. It's not just a one-size-fits-all solution anymore.
Yeah, it's really amazing how far we've come.
It is.
We started with a historical paper from 1964 and ended up talking about, cutting edge treatments of the 21st century. It's pretty cool.
It's amazing what we can do now.
It really is. Well, this has been an incredible deep dive. And for all of you listening out there, if you're dealing with recurrent patellar dislocation, you are not alone. There's help out there. And with the right treatment, you can definitely regain control of your knee and get back to doing the things you love. I think Bratstrom would be proud.
I think you would too.
This has been the deep dive. Until next time, keep exploring, keep learning, and we'll see you all back here soon.